As healthcare moves away from traditional fee-for-service models, providers need a strategy to stay competitive. That's where Strategic Healthcare Partners comes in. We offer expert consulting and ongoing management oversight for providers looking to form an accountable care organization. From financial feasibility analysis to helping you choose the right ACO in a crowded market, SHP provides the clarity you need to make informed decisions and transition to value-based care. Learn more at shpllc.com.
Well, I'm excited that I'm sitting here today with two wonderful people, one of whom I think most of you know really well, and that is Jason Crosby. Jason, welcome to the show.
Good morning, Aaron. Good morning.
And we're joined today with Matt Usher. Matt has joined the episodes before, and he's always given us really great insights into what's going on in the industry. So welcome to the show, Matt.
Hey, Aaron. Hey, Jason. Happy to be here.
Happy to have you here. So kind of before we launch into all the questions, maybe we have some listeners who don't really know what you do. Can you kind of give us an intro of who you are and why you're considered an expert?
Yeah. Appreciate the expert comment. We'll see if I can live up to it. But I've been in the employee benefits, so primarily medical insurance and other core benefits market for close to 20 years now. And we're in Georgia, so we're helping clients with businesses down to 2 employees, all the way up to we work with employers of over 1,000 employees, and again primarily focused on that medical insurance piece, but really all things benefits related outside of 401k plans. With everything that's going on in our market, so much volatility kind of rest on the medical insurance and healthcare delivery and healthcare finance. So that's really where I spend most of my time, is trying to solve those issues for employers and improve the experiences that they have and their employees have when they actually need care.
To jump right in on that note, you had mentioned the smaller employers, and we are very timely with some news. I think as of this recording, we're 48 hours post a significant announcement, at least in our state. Those that are listening know we're in Georgia. You had Cigna Oscar announce a departure on their, they have a pretty competitive, fully insured small business product, as I recall. Why don't you talk to that and what that does to not just the Georgia market at 25, but what that typical departure and the impact it can have for our small business listeners?
Yeah, very, very recent news, just as of Tuesday, like you said, and just to define that small business market, because a lot of people might not really know what that means. In Georgia, if you're an employer that has 1 to 50 employees, typically full-time employees, then you are purchasing insurance in the small business market. So Cigna Oscar entered Georgia's small business market as kind of a coordination between Cigna, the health plan, and Oscar, the technology company. And they really created a pretty unique set of products. And that occurred back in late 2019, I think, is when they really went full tilt in the Georgia market. So expanding kind of beyond Atlanta to almost the whole state. At that time, they came in, they were very competitive. They gave a lot of our clients that were in that fully insured market an opportunity to maybe improve their plans or reduce their cost. But shortly after their entrance into the market, because that market is so price driven, they picked up a lot of business. They grew rapidly. They dealt with some growing pains, and unfortunately, they've announced the news that we're talking about today. They're exiting that small group market in Georgia. And honestly, it doesn't really surprise me, because going back to it being price driven, if you're just 1 or 2% less in that market, you're going to get a majority of the business, because employers are looking to save money in that market just about as any way, shape that they can. As long as you still have somewhat of a quality product, if your price is less, they're going to consider it. And that market has just been so volatile lately because you had Humana exit just in the last 12 months. So, we lost another fully insured company just a year ago. We still have clients that are on Humana plans that are going to be rolling off in the next couple months. And a likely step for them would have been to go to one of these Cigna Oscar plans. And now it's kind of like, all right, well, you had to stay in this market. You stayed with Humana for as long as you could. Unfortunately, Cigna Oscar isn't even really going to be an option for you. And even if it was, it's only another 12-month solution. So the big picture, if you're a small employer in Georgia, you've now lost 2 companies in the last 12 months. And that really leaves 3 companies that are in the market. And you can't see this, but I'm doing air quotes because just because you're in the market doesn't mean that you're actually competitive. So even though there will be a couple insurance companies and maybe some regional insurance companies that participate in certain areas of Georgia, the cost for those plans is going to continue to rise. And it's really unfortunate because we went from maybe a 7 or 8 insurance company market, kind of pre-Affordable Care Act, to now we're down to, like I said, 2 or 3. And again, if you take into account their actual competitiveness, it's really going to be like 1 when it's all said and done, because you may not be able to afford the other 2 companies just from their premium standpoint.
So maybe dive in a little deeper. So we're midway through the year. I guess that's one good thing, I guess you could say, about such an announcement. At least it's not terribly late for the small business owner now. What kind of guidance would you give them? Okay, hey, you've got some time. It's June by the time they're listening, let's say. What guidance would you give to them now to start preparing, knowing that news that there's less out there for them to explore like that? What would you tell them to do here at the halfway point?
Yeah, the good thing is that timing piece. So the first thing is, hey, don't panic. Regulation wise, they have to give you a certain amount of time before your plan would be non-renewed. So time is on your side. What we're going to be communicating with them is we have time, but we're not going to just lackadaisically approach this. We're going to go ahead and get ahead of what those other options might look like, conceptually talking through non-traditional plans, because that is a big part of what we're doing today with our clients. So stepping outside of that traditional market, which many of them have already heard this, but it's just, for every carrier that exits the fully insured market, there's 5 or 6 new non-traditional companies that are coming into the market trying to grab some business. So while one market is less competitive, there's plenty more options that you should be discussing. So really just kind of taking the time to make sure they understand that education piece, understand their options, but also trying to address it strategically. Maybe you are a 7/1 renewal or an 8/1 renewal or a 9 or 10/1 renewal, or one of those off-cycle renewals like what we call it. Well, your options on January 1st are probably going to be the same as the options that you would have on 7/1 of 25 or 9/1 of 25. So you can take advantage of this market exit by Cigna Oscar and maybe realign your plan and go ahead and move to one of these alternative plans, hopefully to save money or improve your plan design versus what you have with Cigna Oscar. So we're just kind of giving them the options. Hey, educating what's out there. Financially, doesn't make sense to consider this ahead of your exit date, right? So why keep riding the train all the way until it falls completely off the train tracks? Let's take action now if we can, or if it makes sense, but also just not to feel rushed about it and to be comfortable with whatever direction they're going in.
Now, Matt, you obviously you're focused on the Georgia market, but I'm sure you talk to others in the industry outside of Georgia. Are we seeing this play out, or is this just a microcosm that's happening here locally in the Southeast? What are you seeing? Is this a nationwide issue? I guess is really the question.
I believe it is a nationwide issue. I relate this whole small group, so small business experience, to the Affordable Care Act implementation in the individual market for the years of maybe 15, 16, and 17. I think I may have touched on this the last time, we did a show, but the Affordable Care Act actually implemented the rate regulations in 2014. So even though it was passed well before then, the actual premium impact that it made to the market and the underwriting impact didn't occur until 2014. And what we saw in the individual market was 5, 6, maybe 10 companies, depending on what state that you were in, participating in that individual market. They had relatively good premiums, all things considered, and they had pretty rich plan designs. But as time went on, because it is such a price-driven market, being 1% less, being 5% less, being 10% less meant you could potentially get a significant market share of the business. And market share usually is a good thing for most businesses, like you want market share. But in the health insurance market, it can be a bad thing because you're getting all the risk and you may end up getting too much of the bad risk. So what happened from 14, 15, 16, and maybe 17 is, again, going from 7 or 8 companies offering plans in that individual market down to, in Georgia, in certain counties, you only had one insurance company. And that existed for maybe 2 or 3 years after that whole exit from the other insurance companies in that market. Now it's kind of funny, in the individual market, we're back up to maybe 6 or 7 carriers in Georgia. So it kind of went from everyone was in, then a couple of years down the road everyone was out. They all kind of regrouped, rehuddled, and now they're back in. And during that time period, those premiums have actually stabilized. I mean, of course, they're going to continue to go up, annually, but the trend increases in the individual market are certainly a lot less than what you see in the employer market, especially in the small employer market. So I'm kind of looking at it from a standpoint of, hey, what did we learn from the individual market? And is the same thing happening to the small group market? I believe it is. I believe we're getting into a situation where when you only have 1 or 2 companies left, you're going to get all the risk, and there's going to be some bad risk in there. I'm kind of trying to see, what's this going to look like 3 or 4 years down the road. I imagine that we will have more companies come into the marketplace, but their plan designs, their networks, their steerage, those types of things are going to have to change in order for them to be affordable and to be able to manage the risk. And that's exactly what happened in the individual market. So I know it's happening in Georgia. I do believe on a national level, it's also happening, to your point, Aaron. A lot of these insurance companies operate in 30, 40, maybe all 50 states. So, you have to look at the Humana exit was national. Cigna Oscar, I think, is still going to be regional, but in the other states that they operate in, I wouldn't be surprised if they have similar experiences where, they might be taking a step back or maybe increasing their premiums above market average to kind of offset new risk.
Speaking of risk, that's a good segue there. We are seeing a lot of risk, not just in the patient side of the market, but also in the provider side of the market too. There's all of these, and if anyone's listened to this show for any length of time, they've heard us talk about these market disruptors, the big names, Best Buy, Walmart, Amazon, entering into the healthcare field to provide more direct primary care, for lack of a better term, outside of the world of insurance, and in providing clinics and that sort of thing. But there's been a lot of headlines now showing that is even undergoing some turmoil. I know that's kind of extra insurance, but it certainly applies to this conversation. How is that shaping the industry right now, and where do you see that headed?
Yeah, it's been really interesting to see the recent news of Walmart basically getting out of their private clinic or primary care type of strategy. And it's interesting because you look at these companies like a Walmart or an Amazon, they have their stuff together. That if we're talking about volume or we're talking about scale and disrupting a market, they have the tools and resources to be able to do it, but they haven't dealt with the beast that is healthcare and how confusing and complicated healthcare is. So I'm sure that there's a lot of things that they were going to do and might have even worked and implemented strategies that would actually disrupt the market like you're talking about, which from the consumer side, you want more access to care, and you want easier access to care. And from the healthcare side or health finance side, you want a reduced way to receive that care. But it's just a beast that hasn't been able to be tamed. So I've kind of followed it, not near as much as y'all have, because I know that y'all been talking about some of these things for well over a year now, when the hot topics of Amazon and Walmart and Best Buy and stuff like that. But I think one of the things that I've recently kind of thought of at a high level, and I have to give some kudos to Dr. Eric Bricker, because he was the one that really helped open my eyes to this piece. But there's a belief that primary care is kind of like a loss leader in the market. And with all of the provider consolidation and all the vertical integration, so we have it on both sides. You've got providers being bought by larger provider groups or hospital groups. You've got insurance companies buying provider groups or buying, the surgery centers or hospital systems, and consolidating or vertically integrating to keep care within their channel. And thinking of it as a loss leader, you're just trying to get the person in the door for that primary care visit, but you're really going to make the money when they're referred to a specialist within your organization, or when they need surgery or imaging within your organization. So I think one of the main stumbling blocks to the Amazon strategy or the Walmart strategy is, if you're focusing just on the primary care piece, you're really not generating the revenue that you used to be able to generate in that market. And the true revenue comes from these referral and specialty care and surgical care and stuff like that. So that's something that I hadn't really thought about until this recent news. And you kind of peel back the onion and you think about it, that these primary care doctors are getting suppressed, right? From a timing standpoint, they only have a few minutes with each of their patients. I know that the insurance companies are beating down their negotiations every year, right? So they're spending less time with the patient, they're getting paid less, yet these larger organizations are still buying them, right? And they're buying them so that they can keep that care steered within their organization to be profitable services.
Yeah, and I also think there's the kind of that tech bro mentality that comes from these bigger companies like the Amazons, where hey, we'll just write some lines of code and somehow magically the process gets better. I have felt long that this approach of these big names wading into healthcare was very much a we can burn all the money we want and somehow we're going to improve care. And I think they've discovered that they might as well just be pouring gasoline on the fire, because that money's burning and care hasn't improved. So it's, yeah, I think it's kind of this tech bro approach of, I think we could fix it if we throw enough money at it. I think they're discovering you can't.
Yeah, it feels like too, a lot of them are taking the retail mentality and the focus, to Matt's point, on the primary care side, and also telehealth, wearables, that sort of focus, where in their minds, in the retail world, it's, I paid X to produce this product, I'm going to charge Y to incur the margin on selling that product, knowing that healthcare, none of them tackled the nut of payer reimbursement. We're not a X cost equals Y margin financial industry, right? And it feels like a lot maybe did not appreciate that. We've talked a lot, Aaron, Amazon, Best Buy, you name it. It feels like if there's a retail shop, we've mentioned it, Walgreens, et cetera.
I'm half expecting Piggly Wiggly to wade into the game.
That'd be great.
Yeah, grocer and the diabetes management kind of goes hand in hand, right?
Yeah.
Why not? That's right. Lifestyle change, but even I'm curious too, like Amazon, their chief medical officer announced he's leaving, and he's been there from the get-go. And usually that spurs further news by an organization. And so I'm really curious where Amazon Clinic goes, which of course put a ton of money. I think they even revamped what they were calling their health initiative, right? And so I don't know, Matt, if you're thinking too, it almost feels like we're going to have a pause maybe, and then a rebirth for the third time of what retail disruption actually looks like.
Right. And I think, the only one that appears to not be getting some negative publicity right now is, to your point, going back to telemedicine, but Aetna, CVS, the walk-in clinics, the minute clinics, right? They're probably using some of that service as the loss leader to drive bodies through their doors at the retail clinic, but they also own the payer side too, right? So having that insurance piece tied into it, of course, all those people aren't insured with Aetna, right? But the people that are insured on an Aetna plan that do get their care through the doors of a local CVS Minute Clinic, there's a lot of, to your point about the reimbursement, there's a lot of levers that get moved behind the scenes, right? And when you're controlling the payer and the care provider and also the retail facility all in one, that model seems like it might be sustainable, or it might be marginally effective. But also I just haven't really heard much negativity about it. So it does lend me to believe that when you control the payer side of things, then you might be able to do a little bit more disrupting or more impact in local communities.
That's a good point.
Let's take a quick timeout. We'll be right back.
Provider enrollment. Not enough time to efficiently enroll your next provider with payers? Is the medical provider enrollment process too cumbersome to keep aware of internally? SHP offers an automated provider enrollment service. We deliver accurate, signature-ready documents quickly, meeting payer requirements. Our established relationships ensure a smooth process. Visit shpllc.com for details.
Read more news recently of, who's it, Walgreens and LabCorp. You can go where a lot of employers are sending folks to LabCorp. You can go use the LabCorp and Walgreens, obviously, to go do your initial drug screening. And so the theory being, from Walgreens' perspective, we get them in the door, then they're going to have to buy something. Well, Walgreens, there's there's magazines, there's whatever you got to buy, more prescriptions. And so to your point, maybe it's not the health industry, it's just foot traffic in the door, Disney approach. They're going to ride a ride, and the first place you walk through as you get off the ride is into what? A retail shop to buy the products, right? So maybe
Right.
That's actually a good point. Yeah, CVS and Walgreens, who would have thought that? Maybe not necessarily a standalone product line, but just a feeder mechanism into the retail place.
Right. And that still applies with kind of the Walmart or the Best Buy model, but the problem is that they don't have that payer piece of the puzzle, right? They're not tied in directly with a specific insurance company. So I think that's what rounds out CVS's position right now, at least, is because of that integration with not only the PBM side, CVS Caremark, but also with the insurance side, being Aetna's health insurance at the small employer at the individual level, and the the mega employer level. So they're really tied into all aspects of it.
Mm-hmm. No, good point. Good point. All right, let's maybe pivot a little bit here. We touched on the last time you were on, which has been about 6 months, a little bit on direct primary care and movements that it may or may not cause in the market. We here, at least in the South Georgia, we hear a little of it, some rumblings, but you don't hear much about it beyond that. But I'm sure you live in it much more than we do. Touch a little bit about what maybe you're seeing in that market, if anything. Have you seen as much movement maybe in these last several months?
Yeah, we've been talking about this for what feels like years.
That's right.
The DPC or the MD VIP model or the concierge doctor model. And I think as a consumer, I love the idea, especially as regular healthcare kind of progresses, going back to my little tangent about, seeing a primary care physician, maybe only having 5 or 7 minutes of their time for that visit, or maybe having to wait 3 months for a sick visit because of how overbooked they are from a patient side. Everyone wants the direct primary care model to actually work when you think about it at the consumer level, because you want that old school interaction with your physician. What existed 20, 30 years ago. See my doctor here, call him up if I have a problem, have him run by the house if I have something going on with someone in my family. Just more of a friendly interaction, care interaction, and really trying to do the best for you in that moment, no matter whether that moment is a 1-minute text message or a 50-minute office visit. So I love the concept of it. The challenges kind of relate to talking about Walmart and Amazon. Healthcare is complicated, right? So you can solve the care side by having this direct primary care arrangement where now you do have a doctor on call per se for you or maybe your family members. But if you don't solve the payer side of the equation, then it makes it really challenging for that to grow at scale. So the challenges that we run into is obviously none of the major insurance companies are going to have a plan set up where you can coordinate direct primary care and have it either come out of your plan dollars or reduce your premium because you have a direct primary care physician. So that won't exist in that model until the large insurance companies figure out a way to kind of integrate that. There's plenty of other alternative, non-traditional plans that have different strategies and approaches that they would implement to help employers save money, but not many of those have the ability to actually reduce their stop loss premiums if you implement direct primary care. So I do think that is a bigger trend in that kind of non-traditional market. You're starting to see a lot of these third-party administrators and stop loss companies work together to kind of come up with what they would call maybe a bundled type plan arrangement where, hey, if you implement direct primary care, we'll reduce your stop loss premium X, or we'll carve out claims Y here that would have been going, to a network primary care doctor, and now it's going to direct primary care. So I think we still have a lot of work to do in our industry to make that easier, because an employer doesn't want complicated. Employees don't want complicated either. So, there's so many different components to that. The challenges that I kind of see that limit that model is scale, right? So these direct primary cares are taking on maybe 600 to 800 patients. So the only way that you increase scale is you have more DPC physicians come into the market, or you ask that DPC to go from 600 and 800 to 1,000 or 1,200, and now you lose that appeal of being able to really spend time with the patient, like what we're all looking for. And then the other piece of that is having that insurance integration, right? Without having the scale or without having the insurance integration, it's kind of two forces kind of bumping up against each other. And I think the adopters of it right now are, maybe a small business that is able to integrate that and reduce those premiums, or a private payer just saying, look, I just want a DPC on my own. I'm just paying for it. I don't care what my plan does. Or a business that's located in a geographical area where there are a lot of direct primary care providers, right? And then you can implement this strategy to a larger employer and also have the ability for your employees to be able to kind of pick their DPC, right? We're not just shoving you to one direct primary care provider. We're giving you the option of being able to pick from maybe 10 within this geographical location.
Mentioned it on the podcast before. My PCP is a DPC, and I switched to her a year ago. I had a big health thing occur, and I called up my PCP, which is in my plan, and they're part of a big network, all that stuff. And I had a medication question after I'd been discharged from the hospital. And I was told, well, you have to see the doctor first after being discharged before we'll answer any medication questions. And I said, okay, can you see me tomorrow? Like, when can you see me? This is a pretty urgent situation. And like, well, the earliest we have is May 15th. It was April 8th when I asked that question. And I said, okay, that's it. I'm switching to a DPC. Not only did she onboard me within 24 hours, but she was able to answer my medication questions. Now, ultimately, I ended up going back to the hospital. That's a whole other story. But she was there kind of the whole way and has been there through my recovery the whole way too. I can text her on weekends, and she's going to respond to me. But it is one of those things. It's like it's an additional several $100s a month for my family. In addition to the insurance that I already pay for, it doesn't go towards any of my deductible. So now I've effectively increased my own cost of care, but I'm actually using my insurance less, and there's no reward for me to do that. And I'm taking a burden off the insurance company, and I don't see any of that return. Now I do it because I need access to care right now, and so it's worth it ultimately for me to do that. But I think you raised some really valid points of it discourages DPC use by the way that we have it set up with the insurance companies today. And I know of 3 DPCs in my immediate city, which is rare for a city my size of about 30,000 people. We have 3. And I think all of Savannah has like 3, and they're 10 times our size. But if there was a way for us as consumers of insurance and of medicine to have a more fair system where maybe I want to have our cake and eat it too, but you highlight some huge weaknesses and drawbacks that we certainly feel, and it almost feels like it's intentionally set up that way to discourage us from DPC. But it certainly feels like that's the way to getting access to care is through that DPC model, if you can afford it. We're blessed that we can. So I guess kind of where I'm going with all this is then why we are driven the way that we're driven. These insurance companies they're driven by their metrics. They look at the direct primary care model as not being measurable because it's not that efficiency, right? If the doctor needs to text me on the weekend, she does so, or she spends 50 minutes with me when it should have been a 15-minute appointment because she's actually providing care. That flies in the face of insurance metrics. So let's kind of talk about that and how is that driving both employers and insurances towards this rush to the bottom, if we want to call it that.
Yeah, absolutely. I think the metrics are just going to get more and more important. And I know that you guys deal with a lot of this kind of on the Medicare payer side. I know that there's a lot of value-based care types of situations. And I'm sure I'm fumbling up the terminology because I don't deal with it every day. But I think that one of the approaches that these, again, non-traditional third-party administrated companies are taking is more care being steered, if possible, to high value or high quality care practitioners. And it's challenging because going back to your point, Aaron, I had the same type of interaction with my primary care. So I feel like there's a lot of grassroots marketing being done for direct primary cares just through those kind of experiences of, hey, I haven't been able to see my doctor. I rarely get sick, but the one time I do get sick, I can't see my doctor for almost 3 months. I love my primary care, but he just can't see me, right? So now I'm going to go see another primary care within that organization. I spend literally 5 minutes with them. I get prescribed a medication. I get prescribed a second medication to deal with the side effects of the first medication. All in from check-in to exit was 17 minutes, which most people would be like super pumped about. Hey, I had a really quick doctor's appointment, but I actually needed some attention and it didn't happen, right? So, those experiences will drive me towards direct primary care. And just like it kind of drove you. And I think that that'll continue to happen in the market. And that's just going to be a very long way of getting that model to become more and more popular. But getting back to kind of the metric side of things, what we're seeing is this whole health care steerage, access to care, finding care is so complicated that what we all do is anytime that you need some type of care, how do we figure out what doctor we're going to go see? We typically ask our friends, right? Hey, who did your back surgery, or who did your shoulder surgery, or your knee surgery, or who'd you see for your migraines, right? And we're getting advice from one of our friends. Obviously, we trust them or trust their opinion, or maybe someone else in our social network, right? But we really have no idea, was that care quality, right? Like, did it actually address the situation? Was it the right standard of care? Was it the right treatment protocol? And frankly, it's very complicated to even figure out how we kind of critique or measure physicians in that world. So that is an innovation that I'm really excited about, kind of in the third party market, and also the care navigation market, is being able to give consumers, give employees the tools and resources to be able to actually find quality physicians for the types of care that they might specifically need. And I was at a conference just a week ago, and I had a kind of a weird light bulb moment, but also a scratch your head moment, because these conferences, you have a speaker comes in, they talk for about an hour. You either move to a different room with a different speaker, or a new speaker comes in. And back to back, my sessions were direct contracting was the first session, and talking about how great direct contracting is and how it's the wave of the future for health plans. Into the second session was care navigation. Direct contracting is flawed, because how do you know that the direct contracts that you're creating are actually with quality care providers, right? So for instance, if you have to have 3 surgeries, even if they're a quarter of the price, but you had to have it 3 times, you're really costing your plan money by having direct contracts with that particular provider, versus giving your employees the tools to actually see, the best or the top 5 provider for that particular situation. And one thing that was kind of eye-opening to me is, you look at some of these centers of excellence, the tools that exist to show what might be the top facility for you to go to. But the tools that are coming and that do exist today, but are going to become more mainstream, are the tools showing specifically what physician within that facility is the one that you need to see, and what facility is the one that you're going to get the best outcome for that particular care episode. So, taking an orthopedic group, right? There's going to be people that are super specialized in one particular type of procedure. Of course, they can do all types of procedures, right? But you want to make sure that the doctor that you're using is the one that is really super specialized for that particular situation that you need. So if you just look at the organization as a whole, yeah, they've got great outcomes for ABC procedure, but the doctor that might actually be doing ABC procedure on you might be the worst doctor within that facility to do that procedure, right? So you think you're going to a quality provider, and as a whole, they might meet those metrics, but at the provider level, they might be falling below that metric, and you really have no idea. And then the second piece of that puzzle is, how do we steer care to the highest quality facility? So again, that orthopedic surgeon, they might be able to perform that care in 15 different hospital settings, or 5 different ambulatory surgery centers. Well, their actual quality outcome metric, so your readmission rate or your success rate for that particular procedure, that could actually vary by location as well. So they might be really great when it's done at one particular ASC versus when it's done at the best hospital system in your area. So those are the kind of things that really excite me, because I go back to that anecdotal story about, well, how did you know which back surgeon to go to or which doctor to go to? It's word of mouth, right? There's really no value in it other than, hey, a buddy of mine had this done. I think empowering people with the tools to be able to find those quality care physicians is going to become more important in the health insurance market. And I think as that becomes more important, it's going to be really paramount for those provider groups to make sure that they are keeping up with their metrics, so that as 10 years from now, when employers are steering people to this clinic for this type of care, how is that provider group going to compete with that clinic to earn that piece of that market share? There's a long way to go for that, but I do see that as being an exciting piece of the business, and also something that providers should be considering when they're either doing these direct contracting situations, or also just keeping track of their own metrics for readmissions, re-surgery situations, follow-up care, complications, and stuff like that.
Well, I don't know about our listeners, but I solely rely on using Yelp to pick all of my providers for my really important surgeries. That's the number one way that I pick a restaurant. Why not my care?
Right.
Shout out to Yelp. I know we're coming up on time, but I'm interested to get your thoughts on this, Matt. And I'm going to do what we do very well in here, and I'm going to completely just pivot to another talking point. It's still tied to holding different parties accountable. So earlier this year, we had a lawsuit filed against Johnson & Johnson, kind of piggybacking the ERISA health plan and the amendment from the Consolidations Act back in 21. That had to deal with a lot more kind of transparency, as how I take that sort of amendment in terms of cost and pricing and such. Speak to that a little bit more. You obviously live in that much more than we do, but I found that intriguing as something that should maybe shake things up a little bit. Speak to what that brought up this year and how maybe that impacts some of our listeners.
Yeah, this is a classic case of good intentions perhaps gone bad with legislation. I think on the surface, everyone agrees that the Consolidated Appropriations Act was a good thing. It had, the price transparency pieces to it, where hospitals have to post their prices. It had compensation disclosures, so we as brokers, agents, consultants, whatever you want to call it, we have to disclose our compensation to our clients. It had gag clause language in it, so that whoever you're using from an insurance company or some type of third-party service provider or PBM, they have to make sure that they don't have gag clauses in their policy. But it also comes with this fiduciary responsibility piece. And the main industry kind of point and reference is going back to how fiduciary responsibility really shook up the 401k market, over a decade ago. So I never have been on the financial planning side of things, but obviously the same type of regulation or similar regulation was introduced to 401k plans. And it did change a lot of the fee model and service model and stuff like that. So I've been trying to kind of find that correlation to what it actually positively impacts when it relates to healthcare and all the various providers within the healthcare model. But I will say the one correlation is the main attorney that made hay on all of the fiduciary lawsuits during the 401k market disruption is now going after the healthcare market disruption. So forgive me because I'm going to blank on his name, but he was solely responsible for over like $2 billion of the $6 billion lawsuits that were in that 401k market. So now we're talking about healthcare, which everyone is involved with. It's a much larger market. There's a lot more money out there. And I do think that these lawsuits like the J&J lawsuit, and there's been many others, are going to come about. And what it really boils down to is your employer being fiduciarily responsible with your money? As an employer, you are picking a health plan for your employees. Is that health plan in the best interest of your employees? And are you paying for your care in the best way, shape possible? Which I think we can all agree that there's a lot of fluff and there's a lot of overspend on the commercial payer side, whereas some payers might pay 600% of Medicare for certain things, which we would agree, hey, that's probably not responsible, and you're not doing your plan members service by paying that much for that particular procedure. The problem is you don't really know about it. As an employee or as a member of that policy, you don't really see how egregious some of these reimbursements are. And that's what these lawsuits are kind of uncovering is you've got employees that are suing their employer because they are the fiduciary for the plan. And then you also have plans like the Kraft lawsuit that are suing the actual insurance company. So the insurance company not being a fiduciary by providing claims data and other types of analytics to the actual employer. So I think it's going to be a hot button. I think there's going to be a lot of money that will change hands, whether it's from an employer to a class action or whether it's from an insurance company to either a direct employer or another class action. But it's definitely the new thing. And I think we can all agree that when every billboard that you see is related to some type of accident attorney, it'll be interesting to see how that translates to the healthcare world. Because again, people don't have car accidents every day, but people use their health insurance just about every single day. So there's going to be an abundance of opportunity for attorneys to make money in this market. And I guarantee you they're already looking at the way that they can kind of create their own niche and figure out what type of either business or what type of insurance company they can target and have a competitive advantage over. And once they understand how that works, it's just going to be wash, rinse, and repeat. And they're going to try and extrapolate as much money out of the market as they can. So it's very important for employers to be thinking about this because the potential of a lawsuit is unfortunately probable. The challenge is, as a small employer, going back to kind of the market that we work in, there's not a lot you can do to really make sure that your plan doesn't have these gag clauses, to make sure that your plan is being fiduciarily responsible, to make sure that you're getting the data that you need out of either the plan or the PBM or whatever it is. So it's scary, but it's scary because I don't think small employers are going to be able to really manage it very well. And I hope that this doesn't end up being a main way that they lose money through litigation. So these are things that we're kind of working on, but also not having all the answers and having to rely on some of these third parties and the insurance companies to really help make this be transparent for the employer and the employees. Those are the big challenges that concern me.
Wow, that's it's certainly something to think about and be aware of, and as the market continues to shape and evolve. Well, Matt, we're actually well past time. First off, thank you for joining us today. Wonderful conversation as always. And honestly, we could probably go another hour and still not cover everything that we want to cover. So when I introduced you as an expert, I hope people understand why I say that, because your knowledge and your breadth of knowledge on this is phenomenal. So thank you for being on the show with us today.
Well, I appreciate those comments, and I really do love this opportunity because you two bring a unique perspective given the type of business that you're in, and it's one that I don't completely understand, because it is so complicated. And just as much as you may think of me as an expert, the feeling's mutual from across the table. So, like I said, I love the opportunity to talk with y'all and chat with y'all, and I agree. I could go on for another hour, I'm sure, and I could learn so much more from y'all as well. So thank you for having me.
Yeah, well, thank you for joining us. This has been an episode of Beyond the Stethoscope, Vital Conversations with SHP. If you enjoyed this podcast, please be sure to rate and share it with your friends. It sure helps the show.
Production and editing by Nala Weed. Social media by Jeremy Miller.
And our co-hosts are me, Aaron C. Higgins, and Jason Crosby. Our show producers are Mike Scribner and John Crew.
Thank you for listening, and we'll see you next time.
Now, before we go, there is one final question that I'm sure our audience just is dying to know. Are you a beach vacation guy or a mountain cabin vacation guy?
I'm a beach vacation guy.
That doesn't have anything to do with being near the beach, or did you move here because you're near the beach?
So I grew up on the beach, so I should be the mountain vacation guy, right? Because I should have had enough beach time. But there's just something about a good breeze, a nice beach chair, and the sound of the ocean waves. I don't know if I can get any more relaxing than that. So that's what I like.
That sounds fair. That sounds fair. Alrighty, thank you again, Matt.
All right, thank y'all.
You already know that understanding your data is key to improving patient outcomes and financial performance. But how? At Strategic Healthcare Partners, our analytics services help turn your EMR and other data sources into actionable insights. From identifying areas for improvement to guiding you through implementing changes, SHP supports you every step of the way. Our performance analytics service dives even deeper, providing custom reports that help you stay ahead in the transition to value-based care. Unlock your data's full potential with SHP. Learn more at shpllc.com.